Welcome to SLP215. Alrighty, we are in module 5. Let's get there. Okay, fluency. Here we go with 50 names for the same thing. So fluency, when you hear an SLP talk about fluency, we're usually referring to, our speaking rate. A fluency disorder is usually, we say stuttering. There are some other, there's cluttering. There's some other things that maybe is better captured by fluency disorder versus stuttering. But I would say the general terms when we're talking about a fluency disorder, we're talking about stuttering. So stuttering. Obviously, we're looking at fluency, how we're saying the words, speaking, and let's talk about some of the signs of stuttering. So repetition of words or parts of words or sounds. So sometimes you'll see, the where are you going? So that's that part word. Sometimes I'll call that more sound repetition, or if we're just kind of repeating that one sound. Sound prolongations can be like you can't, it's not, it's save me a seat. So that prolongation, and what's interesting, if we go back to, speech science and kind of the acoustics or physics of sound, oftentimes you'll see those sound prolongations on the fricatives. Because what is a fricative? Basically, fricative is kind of that friction of air. So it's what we call a continuous sound. So look at our class of fricatives. F. Voicing is a little bit different. It's still continuous, but there's less, the voiceless sounds you can do longer. So, and you can do some of the voicing longer too, but not, I feel like there's more prolongations on voiceless sounds than voiced. Like for instance, I have a student who often, he will stutter on the V sound, but not the F sound. So it's a it's more of that sound. There is some prolongation, but it's more of that repetition of sound versus F. Interjections. So a lot of us do this, and to the extent I would say, if it's excessive, then it's a problem. But the like. And to me, what we see in some of that is word finding issues or distractibility, because I see it a lot with our children with attention deficit, as well as in our neuro rehab patients who now have some, what I would call, difficulty with attention, sustaining attention, completing a thought. So the interjections are sometimes finding the word or organizing language too. So we definitely see those go hand in hand. How do we diagnose this? So the challenge that I have, and sometimes, I've been reading some more of the current information. So some people have what we might want to diagnose as a stuttering disorder, a stuttering issue, but it doesn't impact them. They're not bothered by it. It's not impacting their communication. So is it really a disorder? I don't know. I'm having some issues calling it a disorder sometimes in particular cases. So basically what we're looking at, do the disfluency make them stand out? And does it disrupt their communication? So that's kind of, it's twofold. You can have someone who has some disfluencies, or you see someone doing the and that doesn't necessarily mean that it's impacting their communication. So truly, to have if I want to say a true stuttering disorder or true fluency issue, is when it is negatively impacting their communication. So usually we can hear stuttering, and none of us are 100% fluent. Like I said, I stutter the most when I'm on office hours. I can definitely, Did I have a stuttering disorder? You know, if I talk the way sometimes I talk, but part of it is I'm trying to watch the chat. I'm trying to do a couple different things. I think I'm more distracted, trying to make sure, you know, is somebody saying something or letting me know that they can't see the page. So definitely some challenges sometimes with fluency for me on office hours for a variety of reasons. And doesn't mean I have a stuttering disorder. Now, at different points in our life, so we can have some kind of periods where we're disfluent. We can have some of these issues, but is it negatively impacting our communication? Are we working through it? Are we okay? And that's kind of where I go with, do we treat it? So if it's impacting them, if they are changing the way they communicate because of it, if they are avoiding communication tasks or communication interaction, or withdrawing from activities that maybe they normally enjoy or would like to engage in and enjoy, or try, but they aren't because of their speech disorder or speech stuttering issue, then yeah, we want to treat it, because the purpose of stuttering, or treating stuttering, I should say, the purpose of treating stuttering is we want to positively impact their communication. We're not necessarily trying to make them fluent. We're not trying to make it go away. We want to positively impact their communication so they're able to do all that they want to do within their daily life. So, you know, we go through this evaluation. Has it continued for 6 months or longer? Is there other speech and language disorders? And what I also want to say there is also, we also need to consider a lot of other disorders outside of the speech realm. And definitely what I feel for our young clientele is the parents' reaction to it. And maybe that's not the right word I want to say. The family's concerns, fears, focus, how are they dealing with the stuttering? So most children at one point or another have some kind of developmental stuttering issue. It's usually developmental in nature, and it's usually, and I would say 3 to 6. You'll see 2 to 5. You'll see 3 to 5. You'll see 2 to 4. I'm going to say 2 to 6 is really that window of developmental, because let's say they're delayed in some other areas. So there are kids that aren't meeting milestones exactly when they should, but say they're a few months late. So, okay, they were a little bit delayed in walking. You know, there's like this little rhyme. They're a little delayed in walking, they'll likely be delayed in talking. So there are some people that just have sometimes some of these delays for a variety of reasons. Usually we don't know why. And so that the language window, I think, is very broad, especially for our young developmental stuttering window. And really, we can't really predict. So let's say a child starts stuttering. Well, we can't predict how they're going to respond or how everyone else is responding. We try to kind of ease a parent's concerns about it in, hey, typically developmental, is it impacting? And more often than not, it might have on some occasions, but it's not continually negatively impacting their ability to communicate on a daily basis. Maybe in one situation, maybe when they got frustrated, but we're not seeing this regular, almost daily impact. So that's usually a good sign. And where we get a little more concerned is, and we'll talk about secondary behaviors. So more often than not, when we get a child that stutters, it's a developmental window. Now, we have to kind of definitely, what's our focus going to be for that particular client? So let's say it's severe. The child's not communicating in a manner which we feel like they should, or it's negatively impacting, they're withdrawing, they're not communicating as much because of it. So basically what we're going to try to do is, are we going to try to help them speak more fluently or communicate more effectively, or kind of what I would say, help them accept their stutter and stutter how do I put it? Stutter so they can work through it faster. Stutter in a manner which helps them work through it faster so they don't get stuck. So for me, I usually focus on, I don't ever want a person to be stuck. And so that's kind of some things that I focus on when I'm doing an evaluation. In therapy, I like this, and let me know if you can't open this doc. So how effective are treatments for stuttering? Now, I think stuttering is a little more global. It's not just the clinician and the client. It's usually also, we need to really work with their behavior, their family supports, their environmental supports to support them and their communication. So, like I said, I think, where's this word? So SLPs work to help people who stutter lessen the impact of severity of dysfluency when it occurs. And it's not so much to eliminate disruptions, but kind of minimize that impact on their communication. So for me, I always focus on the communication. You might have stuttering episode. It's okay. How do we work through it? How do we make sure our message is heard? So definitely we work on some of those things. Sometimes it's, there's been some reluctance during preschool years. And definitely there's some, they outgrow. I think we're starting to kind of move towards that. It's very hard. I said, sometimes we still recommend a wait and see. Sometimes we address it sooner versus later. And I would say, I want to talk about when do we address it sooner than later? And like I said, my usual benchmark is, how is it impacting their communication? Is it impacting them on a daily basis? Then maybe we want to address it now versus later. But we have to also look at the global picture. Are there other things going on that can impact them? Oh wait, hold on. I don't like this. One second. Let me go back to the presentation. So this is just what I would call some of your basic facts, basic definition. We also refer to it as dysfluency. And I said 3 to 6 here. I will say 2 to 6. You know, like I said, I feel like that window is wide. And typically what we see is if it's lasting less than 6 months. So oftentimes if somebody brings a child for a stuttering eval, you know, if it's just been occurring the last couple of weeks, I'm not as concerned as, hey, they've been doing it since last year. You know, it's September. They've been doing it from the previous summer, so over a year. Oh, okay, maybe it's something we need to start working on. Okay, neurogenic stuttering. Whoops, excuse me. This is what I want to say. What I have seen is there can be stuttering present because of other things. And when I say neurogenic stuttering, and I have had children who have more of the signs of neurogenic stuttering. And really what concerns me about that is I hope they're getting checked out. I hope we're looking at some of these neuro things. I think sometimes some of that neuro-based stuttering is underdiagnosed. And also sometimes a child, for a variety of reasons, and you know, just for a particular population, let's say a child in foster care, we might not know their history and they're presenting with signs of stuttering. Okay, I'm usually a little more on alert, especially if the caregiver reporting doesn't have a good, accurate history. Here's a disorder that I see a lot of stuttering. So cerebral palsy, that doesn't surprise me. I feel like it's most of the time some of that neurogenic in nature. That doesn't mean they can't respond to therapy. I just know sometimes there's more of that neurological piece there that probably will be there. So we need to work with them on what are strategies that will work for them. You know, head trauma, stroke. Oftentimes our adult rehab clients now have lots of stuttering. So for instance, my coworker, she was just telling me actually a couple of days ago, her daughter who's had a brain tumor has been treated the last year, is doing a lot of neurocognitive rehab. She was talking about neurogenic stuttering and how that was just different from her child before the brain tumor. And so definitely we were talking about some of those things that might help someone. And so developmental versus neurogenic, that kind of presents itself different. And I think also our treatment focus is different. Someone who has a degenerative disease like Parkinson's, multiple sclerosis, muscular dystrophy, those kinds of things, that's going to be different versus somebody who just has maybe stuttering in the more severe end, but we don't have other factors. Like I said, cerebral palsy is one we see a lot. Even some things with children with asthma, some kind of breathing related things, because I think they kind of get some of that airflow issues and it's kind of off. So I think airflow, any child that's had a compromised breathing or asthma, even somebody with some extensive allergies, and it impacts their airflow, their airway, that kind of thing can definitely impact fluency. And so causes, so there's 4 factors. There's no, what I would say, a determined cause of stuttering. I think it's a lot of factors in play. I think it's genetics. We do know stuttering seems to run in families. Development, are there other developmental delays? Are there other things going on in their development that has impacted? We definitely see those comorbid things. Neurophysiology. Definitely there's some different processing things. There's some cognitive things that we do know impact stuttering. And family dynamics. So, and when I say that, I want to say, I don't want to say pressure or, you know, intense parents, just because you have, you know, there's intense parents doesn't mean their child's going to stutter. But I think sometimes we have a person who stutters and then everyone's response to it and then pressure. So no, I can be disfluent in an anxious setting, or if I am nervous, I know I'm likely to stutter. I know it can happen. And if I'm having anxiety or if I feel pressure, sometimes there's some kind of dynamic where child speaking, there's pressure for a variety of reasons. And I don't want to fault a parent for this, but sometimes just the dynamics of the family as a whole kind of can definitely impact stuttering. Not going to cause it, but it can kind of, would I say, not perpetuate it or make it an issue, you know, make it bigger than what it needs to be. And then that just adds extra to that component. So no causes, but definitely there are some factors that influence it. And it's usually a combination. It's usually not just one thing. It's usually a combination. So there's no known one cause. We just know there's factors that can influence stuttering. We do know it affects 4 times as many males as females. More than 70 million people worldwide stutter. So definitely there's large numbers. I think this might be one of the most underdiagnosed conditions also. And like I said, I'm struggling sometimes with that diagnosis. For instance, you might have a stuttering issue, but if it doesn't bother you, is it really a disorder? Or is that just our label on it? So definitely what I'm looking for, does their fluency or some of these behaviors impact their communication and their willingness to communicate? So children and adults, I do want to say this. So is stuttering caused by emotional or psychological problems? So children and adults who stutter are no more likely to have psychological or emotional problems than children and adults who do not. There is no reason to believe that emotional trauma causes stuttering. And I'm going to say that with a disclaimer. But if someone who's been through a trauma could demonstrate signs of stuttering. So, And what we're learning about trauma and how it affects the brain makes sense to me, because there's, trauma really impacts on your brain like a brain injury, depending on the level, depending on, and everybody in their life will have trauma at various degrees. And it's kind of how does your body respond to that also. So, for instance, something that might be traumatic to somebody else might not be so much to another person. But again, especially when we're looking at children, like I said, foster children really definitely, I'm more in tune to, we might not know their history. We may not have even what is known. We may only know a small portion of it. And depending on other factors and their environment, they might not feel safe. They might not feel various things that then can kind of compound that issue. So, like I said, you don't go through trauma and you start stuttering, or someone starts stuttering and they've been through something, doesn't mean it's a cause. It could be a correlation. It could be now we see more, the problem presents itself more, but it's not a cause. I just want to say it's something that we consider, but like I said, there's not always a one-to-one direct correlation between the two. Now, common myths. So here's some myths. Be sure you are familiar. So again, while people who stutter may be nervous because they stutter, nervousness is not the entire cause. I know in the instance when I'm more disfluent is because I'm nervous, but we wouldn't call it a disorder if I only ever am disfluent when I'm nervous. Does that make sense? We really need to see stuttering in a variety of settings. We really need to see stuttering at home, at work, at school, in a variety of settings, not just one setting or in one instance. So for instance, we have this, oh, so-and-so stutters when he raises his hand and asks a question in class. Okay, maybe it makes him nervous. Okay, have you ever heard him stutter in other instances? No. Okay, well then that's not necessarily, that's kind of what I call situational stuttering. That's not a disorder. We're not going to treat it. But in the same breath is if we're seeing children withdraw. So sometimes what we'll see is children who stutter are shy and self-conscious, and we see patterns. So again, we're looking more globally versus in individual instances. And if a teacher is reporting stuttering, I should have a parent reporting stuttering, and other people in that child's lives should also report that they see it. So, and definitely what we don't want to say either is that stuttering is a mental disorder. So emotional factors often accompany stuttering, but it's not primarily a psychological condition. So we do kind of support that counseling piece to deal with their attitudes, their response to stuttering, that kind of thing. And definitely, because somebody might stutter doesn't mean that they are not intelligent or not capable. So there's some things that I think still are perpetuated, but I think they're maybe simplified. People stutter because they're nervous. Well, I'll be disfluent sometimes when I'm nervous. Doesn't mean I have a stuttering disorder. And it doesn't mean every time I stutter that I am nervous either. So that's kind of where we have to look at the global, and we have to look at settings, and we have to look at a variety of factors before we say, yeah, they have a stuttering issue, we need to start treating it. Stuttering is just a habit that people can break if they want to. Stuttering is caused by bad parenting. Again, don't want to say that. It's stress between the parent and child that can exacerbate stuttering for sure. So it can add to the issue, it can't cause the issue. And yeah, something about, and I didn't really hear that, forcing left-handed child to become a right-handed, that kind of thing. Identifying or label. So what I also want to say is identifying or labeling a child as a stutterer does not necessarily result in chronic stuttering. So the other thing I want to say, yeah, stuttering again, it's like autism. No two cases are alike. There are a variety of factors that we consider. The intensity and delivery of services vary. And definitely, oftentimes it's more about the client's response to it versus anything else. So, and our focus always is communication. So that's what's hard about stuttering. There's not a one size fits all. Let me go back. So I want to talk about kind of the approaches. So you'll definitely hear about fluency shaping, fluency enhancing, and fluency modification. So I'm probably more in the fluency modification wheelhouse. And there's just a couple slides. Please look at this. I would say this is what I would call, there's some review of some things. What does it sound like? So this slide is the one I want to pay the most attention to. So can everyone see the secondary of physical symptoms and characteristics? So when I get concerned about stuttering is when I see these secondary characteristics. So for instance, there's fluency issues. We hear the stuttering episode and then we see facial grimace or eye contact avoidance, extremity involvement, muscle tension, word avoidance, interjections. So when I start to see 2 or 3 of these, and that means stuttering's kind of up the ante, so to speak. This is more that's going to impact them, that's going to impact their message, that's going to send off messages. Sometimes their nonverbal language is not going to convey what they mean. And that's where I think that secondary characteristics is where I really kind of look at, okay, yep, we need to treat them. Yep, we need to, support them in the best way that we can. So be familiar with that. Secondary physical symptoms, secondary physical characteristics. And these are just kind of examples. Sometimes we'll see what I would call an idiosyncratic secondary feature. And that'll stand out. A parent will say something, a parent will notice that. So there's extrinsic factors and intrinsic factors. So the other key piece I really want you guys to remember is there are extrinsic factors that a lot of times are out of our control. New situations. Are we gonna have a client who we are gonna allow them to go through life not having a new situation? No. Will there be teasing? Can we control what everybody else does? Hopefully not, but we know that is a possibility. Interference for well-meaning individuals? Yes, 100%. Will there probably be some conflict? Sure. So will they have to use the phone at some point, even though it's difficult? Probably, still even in today's age. So those are extrinsic things. So we know they struggle on the phone, they got to answer the phone, okay. But intrinsic are kind of the fear and the shame, anxiety, low self-esteem, or anger. So the other key piece, what I don't like about stuttering is I think it's traditionally been kind of, I don't like to use the word shame, but it's like shameful, or that's like, there's connotation to the word stuttering. And I don't do that. Like I tell parents right away, I use the word. We make it bigger than what it is by not labeling it. Sometimes stuttering is a little advanced for, a 4-year-old. But I mean, by the time they're in kindergarten, I will use a stuttering episode. I will have them tell me what their stuttering episodes typically look like and really try to take the power. So by labeling it, talking about it, letting them know there's nothing to be ashamed of, there's nothing to fear. These are just things that happen, and how do we work through it is what I think I see a lot of support and positive outcomes, because it's that whole, I feel like that, the elephant in the room, we're not going to talk about it, we're not going to say it. Definitely that just amplifies the situation, and it puts more power And I think that just really impacts someone's intrinsic factors. It can, that feeling of shame, that feeling of less than, that low self-esteem component. And the good part is we're seeing that focus on mental health, super, super, super critical for somebody who likely, for many of the people who stutter will likely have it their whole life. So definitely these are things we need to positively influence and kind of, make sure we're giving them positive strategies and a positive mindset about it. So symptoms, you can kind of look at some of these secondary. So you can kind of see this. I like this picture because we talk about the core. Here's the episodes of stuttering. And then we kind of see kind of that next layer, oftentimes disordered breathing patterns. You'll see some of these body movements, head movements, and then it kind of ups its ante. So we'll see clenching fists, something a little more, what I would say, noticeable, face, lip, or jaw tremors, neck jerking, closing of eyes. So definitely we see that. And then that psychological component is really big. So definitely we want to be sure we're able to address those issues in a positive manner. And you'll see a lot of this. There's a lot of shame associated with this, and we really want to get away from that. But this is kind of just a model of what that looks like. Up above, these are just the episodes. This is what we see, and then the bigger piece is more impact, has more impact on the client. So want to just kind of be familiar with that. Like I said, I really work on. I tell parents, I'm going to use the word, there's no shame to it. We need to not be afraid to use it or label it, because that just increases the power. So some things there. So let me just review real quick before we log off here. Fluency, I think, is one of the hardest disorders to treat because I feel a lot of it is like cognitive behavioral therapy. And it's also, I think it's just very loaded with the support group, the client's support system. So there's a lot of parent training. There's a lot of, how do we best support the child, differences of opinions, things like that. So there's a fluency observation, fluency assessment, and then the read and review summary. So read chapter 10. So just a summary, that's going to help you. If you do this assignment before you take the quiz, it's going to help you with the quiz. Any other questions? Alrighty, if not, thank you for joining me. I appreciate it.
Thank you.